Good evening. My task now is to speak on this topic, which is rather provocative. And remember that at the end of the title of this lecture is a big question mark. I would like to start with 3 slides borrowed from Mark Abelson, an interventional cardiologist from South Africa, who is dealing with acute stroke interventions in last 7 or 8 years. And he was the first cardiologist who started to do acute stroke interventions, and he published this in Catheterization Cardiovascular Diagnosis many years ago. And he has nice slides showing the stroke as an allegory to the burning of the house. The house is starting to burn, so the stroke onset. The neurologists and radiologists are discussing about the etiology of the fire and what should be the best strategy to shut down the fire. But before they come to the conclusion, the house is burned. And this is actually the real situation with acute stroke treatment in most parts of the world, including the developed countries. Stroke, I believe, is the disease which, from frequent diseases, is the disease with the poorest treatment. And this has many reasons. Of course, the nature of the disease is the first one. But among the reasons is also that this is very interspecialty, interdisciplinary disease, which needs a lot of specialists to treat effectively. Neurology, radiology, cardiology, neurosurgery, rehabilitation, internal medicine, and so on. The possible causes of ischemic stroke are cardiac and extracardiac. And cardiac causes count for probably more than half of ischemic strokes. Of course, atrial fibrillation on the first place, but there are many other cardiac causes of ischemic stroke. Extracardiac causes are slightly less frequent, slightly below the half. Already today, there is a lot of work to be done by cardiologists in patients with stroke or with a risk for stroke. Of course, besides the basic examination and 12-lead ECG, there is ECG rhythm monitoring, which was discussed today. And of course, echocardiography is very important, including transesophageal echo in selected patients. Cardiac CT or cardiac MRI. A very useful tool, but quite expensive one, is insertable cardiac monitor, which can be like an injection, injected subcutaneously. Of course, then we have treatment approaches to patients in risk for stroke, radiofrequency ablation for atrial arrhythmias, PF or OASD closure, or left atrial appendage closure. But none of them was yet proven to be effective in decreasing the risk of stroke. This has to be proved in future. And of course, there are interventions like carotid or vertebral angioplasty or stenting, endarterectomy, and other which are done sometimes by cardiologists. What is the ideal physician for treatment of stroke in future? This should be a physician with capabilities of a neurologist, a cardiologist, and probably also a radiologist. Such ideal stroke physician should be able to make fast decisions like we cardiologists are used to do. But also simultaneously, this should be wise decision like neurologists are able to do. Such physicians should have a knowledge of stroke neurology, knowledge of stroke cardiology, capable to interpret brain CT and MRI, have advanced knowledge of antithrombotic therapies, and be capable to perform invasive treatment of acute ischemic stroke, including carotid stenting and intracranial thrombectomy. So this is the ideal stroke physician of future. Unfortunately, today there are almost no such people, or maybe a couple of them around the world, but just few of them. Another unknown question is, what should be the periprocedural antithrombotic medication in acute ischemic stroke if we treat it by catheter-based thrombectomy? There are some suggestions, but there are no firm guidelines and no firm evidence concerning this. Another question is whether acute stroke patients could be treated in networks like we are treating today STEMI, because transport for STEMI was shown to be effective, but whether this is the case for stroke, it is not clear. For STEMI, we have a lot of evidence that quick transfer, even between hospitals, is effective when at the end is fast coronary intervention. But this is not known for stroke. It is not known whether patient with ischemic stroke, where the time runs faster than in infarction, whether in acute stroke these patients can derive some benefit. And actually, the first study done in Buffalo in US is putting a small question there. In the last years, there is an increase in reperfusion therapy of acute stroke worldwide. These are the data from our country in the last 4 years. So you see the marked increase in thrombolytics and also some increase in catheter-based interventions, but the increase is far from being optimal. But we expect a fast increase now after the new randomized trials. And this is the coverage of the country by stroke centers. So we have enough stroke centers to cover the needs of the population, but they are not doing sufficient amounts of procedures. We started to do acute stroke interventions in our hospital 3 years ago, and we are in contact with other cardiologists doing the same activity, specifically with the group of Mark Abelson in South Africa and with the group of Ömer Göktekin in Turkey. And we published recently a short paper in JACC about our results combined from these 3 cardiac centers. And the message of this was that interventional cardiologists are able, of course, after appropriate training, to achieve similar results as interventional radiologists or interventional neurosurgeons or neurologists. Why cardiologists might be involved in acute stroke intervention? Because we have large experience with acute percutaneous interventions. We have wide availability 24/7 of our networks. We are used to work quickly, and we have fast track to cath lab. Usually, paradoxically, the times of acute infarct patients between door to cath lab are much faster than the times for stroke patients, but in reality, the opposite should be true, because in stroke, brain is dying faster than myocardium. There is limited 24/7 availability of interventional neurologists and radiologists. In our country, it is quite acceptable, but for instance, in Turkey, where Ömer Göktekin and his team is doing interventions in cardiology department, he told me that they have, in the whole country of 70 million, they have like 10 interventional neuroradiologists doing the procedures for strokes. So definitely the training of these people will take much longer time than training of interventional cardiologists. The questionable cost effectivity to hold separate service is another issue. So how to achieve effective acute stroke interventional programs? Well, the question is about how sophisticated imaging should be done. If we want to be fast, we maybe should stick just to native CT to exclude developed ischemia, developed stroke, large stroke core, or to exclude bleeding, of course. Because to do sophisticated imaging like perfusion CT and or magnetic resonance diffusion weighted imaging, including the interpretation and analysis of the data, it will delay the treatment by about 30 minutes. It will contribute to proper selection of the candidates, but it will delay the treatment. Another question is thrombolysis in major strokes. It is known that thrombolytic therapy is not very effective in the most severe strokes with major artery occlusion. The chance to recanalize a big artery in a big stroke is only about 20–25%. So if catheter intervention is immediately available, whether these patients should not proceed to direct intervention, or whether still bridging thrombolysis is an option. Bridging thrombolysis, of course, is an option whenever the time delay to intervention is longer than 30 to 60 minutes. What should be the ultimate goal of our efforts? To offer acute stroke intervention program to as many patients with ischemic stroke as possible. Probably the discussion about sophisticated imaging versus simple, quick imaging, the discussion about penumbra imaging, could be focused on the separation of early comers and latecomers. So for early presenters, let's say within the first 3 hours, the time is maybe more important, and for later presenters, the penumbra imaging may be crucial. Groin puncture should be definitely done within less than 3 hours from stroke onset. If this is the case, then the success rate of interventions is much higher than when it is done later in the stroke course. We should define minimal workload, probably more than 50 interventions per year, and the minimal service area, probably far more than 500,000, probably 1 million or more, because of to concentrate the number of interventions in each department. And the key tool is interdisciplinary cooperation between the medical specialties, as I mentioned in the beginning. So what are the key messages? Acute stroke can be treated effectively by endovascular intervention. This year, 7 randomized trials were published. All 7 showed benefit from endovascular intervention compared to best medical therapy, which might include thrombolysis. And the benefit is in the range of absolute benefit of 18%. Even patients with severe stroke can return to normal life if treated early. Catheter thrombectomy is indicated immediately after imaging confirms the indication. Eligible patients may receive thrombolysis immediately after initial imaging, but catheter thrombectomy is indicated also in patients with contraindications for thrombolytics. So basically, catheter-based thrombectomy has much wider indication field. And healthcare systems should minimize effort to implement catheter-based thrombectomy into routine clinical practice. In the new guidelines, which were published in the United States and in Canada, and European guidelines are pending and probably will be published before the end of this year as well, it is now clear after the 7 trials that endovascular intervention is class 1 indication. Thank you.